Hello friends, I am Dr. Ashish Dadas, Consultant General and Laparoscopic Surgeon at Samta Hospital and Surekha Varicose Veins Clinic, Dombivli, which is a suburb of Mumbai. Ours is one of the few centers in Thane and Mumbai where we treat patients with chronic venous disease and offer laser treatments to patients with varicose veins. Traditionally, high ligation of the great saphenous vein at the saphenofemoral junction followed by stripping of the vein has been the treatment for truncal vein reflux. The varicose tributaries are treated with phlebectomies or foam sclerotherapy at the same setting. However, over the last 2 decades, thermal ablation techniques have been increasingly used for this treatment since they offer the same or even better results with less post-operative pain and early resumption of routine activities. The thermal ablation of great saphenous vein or short saphenous vein can be done either with laser or with radiofrequency. We have been doing endovenous laser ablation treatments for over 9 years now, and today we'll dwell into some practical aspects of the same. The underlying goal of laser ablation is to deliver sufficient thermal energy to the vein wall to produce irreversible occlusion, fibrosis, and ultimately disappearance of the diseased vein. The mechanism of vein wall damage due to laser is both by a direct effect and also by the steam generated by heating small amounts of blood within the vein. The vein wall should be adequately damaged for the fibrosis to occur completely. Diode lasers are most commonly used for endovenous laser ablation. There are a variety of laser generators with multiple different wavelengths. Today we will be using this 1470 nanometer diode laser from Reveal Lasers. Regarding the power settings on the laser machine, each commercial laser system has a variable control of power. Energy is measured in joules, and the linear endovenous energy density, which is also known as lead, is joules of energy delivered per centimeter of the vein. A lead of 80 to 95 joules per centimeter provides optimal efficacy for successful ablation with low complication rates. But this is for the shorter wavelengths such as the 810 nanometer or the 980 nanometer. For higher wavelengths such as 1470 nanometer today, a lead of 50 to 80 joules per centimeter will give us optimal result. Today we have a 58-year-old male patient with us with bilateral varicose veins. The chief complaints of the patients are, as you can see, dilated tortuous swelling in both the legs in the calf region. Also, the patient complains of dull aching pain in this particular affected area, which is more towards the evening, and it decreases on taking rest and on limb elevation. Apart from that, since the past few months, the patient has been complaining of developing darkening of the skin near the ankle joint and also occasionally itching. So, as far as the clinical classification is concerned, this is a C4 disease. We have done a duplex ultrasound scan for this patient, which shows a bilateral saphenofemoral junction valve incompetence along with incompetent perforators, the below knee perforators in both the legs. So the plan today is to do a endovenous laser ablation procedure for the great saphenous vein in both the legs, followed by treatment of the perforators and also the varicose tributaries with foam sclerotherapy at the same setting. Before we proceed to the operation theatre, a word about the anesthesia used for the endovenous laser ablation procedure. In many centers, it is done as an office procedure using tumescent anesthesia. In phlebology, tumescent anesthesia is the use of large volumes of dilute anesthetic solution which is infiltrated in the perivenous space of the veins to be treated. Such anesthesia serves 3 purposes. 1. It gives a local anesthetic effect. 2. It empties the vein and maximizes the contact of laser fiber with the vein wall, which is necessary for efficient thermal transfer to the vein wall. Thirdly, and importantly, it provides a heat sink around the treated vein, which minimizes the heating and damage of the surrounding structures. The solution used for tumescent anesthesia is 500 ml normal saline with 25 ml of 2% lignocaine with adrenaline and soda bicarb. The maximum dose of lignocaine with adrenaline is 7 mg per kilogram. Tumescent anesthesia is the preferred technique for endovenous laser ablation since it allows early ambulation and the procedure can be done as an office procedure. However, at our center, we do endovenous laser ablation under spinal anesthesia. The reason for this is that despite the local anesthetic, Many of the patients experience discomfort, but spinal anesthesia makes it an absolutely painless one for the patient. Also, doing a bilateral endovenous laser ablation, especially where there are multiple varicosities, it is nearly impossible with tumescent anesthesia. There is a concern raised by the few of the phlebologists about increased chances of deep venous thrombosis after EVLA under spinal anesthesia. But we ambulate our patients early, and we are yet to see a single complication of deep venous thrombosis following endovenous laser ablation in any of our patients. So we are in the operation theatre right now. The patient has been administered spinal anesthesia and is in the supine position. As you can see, the paths are painted, prepared, and they have been draped. My radiologist colleague and dear friend, Dr. Sachin Patil, the ultrasonography machine is on my left side. On my right side, we have the 1470 nanometer diode laser by Reveal Lasers, and the tumescent pump, the mechanical tumescent pump, is also on the right side, and the trolley on my right side. We'll start with the procedure. How do we ensure the sterility of the ultrasonography probe? We are starting by locating the saphenofemoral junction, as you can see on the sonography machine monitor. So this is the Mickey Mouse sign, which is involving the common femoral artery, the femoral vein, and the great saphenous vein. We'll now trace the great saphenous vein from the saphenofemoral junction. But in this particular case, the patient has pigmentation developing over the ankle, and we would like to treat the vein right up to the medial malleolus. So I'm using a number 18 gauge IV needle for the access. I'm taking an IV access puncture. The backflow ensures that I am in the vein, and which we confirm every time is by locating the needle tip in the vein. The guide wire from the sheath is now being introduced into the IV needle, and the needle comes out once the guide wire is inside. This is a 6 French sheath. So it goes over the guide wire. The sheath is in the vein. The guide wire and the slit comes out. We ensure the IV presence through the backflow of the blood. So as you can see, this is a radial tip fiber. There's a glass tip here which has a smooth end. The laser energy which is delivered by the glass tip has a circumferential deliverance, and that ensures that the energy is uniformly distributed to the vein wall. Unlike a bare tip fiber straight ahead, this one delivers the energy circumferentially. So the chances of causing deep venous thrombosis, especially at the saphenofemoral junction, are very less with this radial tip fibers. Introducing the radial tip fiber into the sheath under ultrasonography guidance, as you can see on the machine. So this is the fiber which is advancing in the great saphenous vein. That ensures that the fiber stays in the discerned vein and we don't stray getting dilated. So we are right now in the thigh. Okay, so this is the fiber tip, as you can see here. This is a very important point which I would like to make. Normally the distance from the saphenofemoral junction, the valve, Dr. Sachin, can you just show us the, yes. So that is the level of the valve. So the fiber tip is ideally supposed to be around 2 centimeters, 1.25 to 2 centimeters from the valve, putting in the measurement. So it's like 1.7 centimeter. Basically, sometimes leaving a 2 centimeter stump may lead to a recurrence, especially in the anterior accessory vein of the thigh. We ensure that the size of the stump, we still maintain the safety in terms of not causing a deep venous thrombosis. So now the most important part of the endovenous laser ablation procedure, and that is the administration of tumescent fluid in the perivenous space, is very important even in spinal anesthesia, because it will help to empty the vein. We have the tumescent fluid in the saline bottle, as you can see. It has only normal saline with soda bicarb to maintain the alkalinity. We do not have the lignocaine in it, obviously. And there is this tumescent pump, a mechanical pump, which helps us administer the tumescent fluid in a faster manner, thereby saving us a lot of time. Under sonography guidance, again, we will be going into the perivenous space, and as you can see on the sonography machine, I'm trying to locate my needle. Okay, so as you can see, this tumescent fluid is being applied. As I mentioned, the tumescent mechanical pump makes our job faster. I again introduce my needle under sonography guidance, and we have to keep doing this procedure till we reach the saphenofemoral junction. So this is the fiber, and I'm going right up to the fiber here, which ensures that I am in the perivenous space. I'll stop here since the fluid is being, it's going more below. The pointer is all along on the fiber in the vein. The heat sink, that is the damage to the surrounding tissues due to the thermal energy, is also prevented. So now we are in the thigh, and here you will appreciate the tumescent fluid will have a better flow, as you can see. As you can see, the vein is being compressed very nicely, and there is at least 1 centimeter of tumescent fluid around the vein. We have connected the radial tip fiber to the 1470 nanometer laser machine here, the Regal by the Reveal lasers, and the machine has a lot of applications. As you can see here, the gynecological applications, professional aesthetics, proctology, ophthalmology, and the vascular, which we are using today. The machine is of a 15 watts machine. We would like to use a lead of around 60 to 70 joules per centimeter, particularly in this patient where the diameter of the vein is around 6 to 7 millimeters. So what I have done here is I have kept the wattage of the machine at 7 watts. It can go up to 15 watts, mind you. And I have kept the withdrawal of 1 centimeter of the fiber at 9 seconds. So this ensures me a deliverance of around 63 joules per centimeter of energy. The reason why I have kept the wattage low is because the lesser the wattage, the lesser the chances of vein perforation and damage to the surrounding tissues. I just set the machine settings, and I'm coming back at the saphenofemoral junction. So this is quite close, as you can see. So the fiber has moved ahead. So I'm just withdrawing my fiber a bit, and we'll reconfirm. This is very important because after the administration of tumescent fluid, sometimes due to the change in the vein dimensions, the fiber is advanced. It gets advanced. So we are reconfirming, and here we are at 1.49 centimeters, and here is the fiber tip. So we are fairly at the point which you would like to be. And now I start applying the laser in a continuous mode. And what I would like you to appreciate is how the appearance is on the sonology. So I'm starting when I'm applying the laser, and that particular break is indicating that we have completed 9 seconds, and in that 9 seconds I'm ensuring a withdrawal of 1 centimeter, thereby ensuring that the energy delivered is 63 joules per centimeter. Following the laser application, we are confirming it on the sonography in the longitudinal section first. So the pointer is on the lasered vein. We'll now show it in the transverse section, which also ensures that we have caused adequate damage to the vein valve. We have finished the endovenous laser ablation procedure, and following the procedure, we apply a crepe bandage to the treated leg with a 1/2 overlap. On the procedure table, we apply a crepe bandage to the treated leg. This is replaced with class 2 graduated compression stockings at discharge. The patient is asked to walk for minimum 30 minutes daily with the stockings on. There are no clear-cut guidelines regarding the use of compression stockings post-endovenous laser ablation, but few studies have shown efficacy in terms of reduced pain and swelling. We ask our patients to refrain from heavy exercises, especially those which increase the intra-abdominal pressure, for a duration of 4 weeks. The patient is discharged the next day and asked to follow up at 1 week for evaluation of minor complications, if any. Complications may occur following the endovenous laser ablation, but almost all are minor. Few patients may experience mild pain or bruising along the lasered vein, but it subsides on its own. If not, oral anti-inflammatory medicines can be given for 3 to 5 days. In some, the treated vein may develop a feeling of tightness similar to that of a strained muscle in the second week. This too is self-limiting. Compression stockings and ambulation, they help in resolving this faster. In those patients where the great saphenous vein is treated below the mid-calf level, damage to the saphenous nerve and resultant anesthesia of the skin is a possibility. However, this resolves on its own in a few months' time. Also, as I mentioned during the procedure, the great saphenous vein needs to be treated till the medial malleolus in cases with disease at the ankle joint. The serious complication of skin burns and deep venous thrombosis, they are extremely rare. Good tumescence and visualization of the radial fiber tip at the saphenofemoral junction has ensured that we haven't faced these complications so far. As far as the long-term follow-up is concerned, we call our patients at 1 year where a duplex ultrasound scan is done to ensure the success of the endovenous laser ablation procedure. This is either in the form of the treated vein shrinking to a fibrous cord which is less than 2.5 millimeters or it is absent on the Doppler ultrasound scan. Literature has consistently shown that the endovenous laser ablation procedure has success rate comparable to both surgery and the radiofrequency ablation. Compared to surgery, the early resumption of activity is a big advantage. To sum up, endovenous laser ablation is a safe, painless and effective way to treat varicose veins. As I mentioned at the beginning that we are amongst the few centers in Thane and Mumbai where we offer endovenous laser treatments for patients with chronic venous disease. In fact, we are the first center in India to start the cryo laser and cryosclerotherapy technique, also known as CLACS, for the treatment of telangiectasias and reticular veins, that is the C1 disease. CLACS is a novel Brazilian technique pioneered by vascular surgeon Professor Kazumiyake in 1999. It is available in nearly 30 countries around the world and is an effective, painless way to treat small varicose veins on OPD basis. As compared to conventional foam sclerotherapy or the 1064 nanometer Nd:YAG laser, CLACS offers long-lasting and cosmetic results. Likewise, we also offer training to postgraduates in general surgery, radiology and other specialties who are interested in this aspect of phlebology. I have always felt that the chronic venous disease is a much ignored entity in our Indian society. The burden of the disease and its morbidity are heavy, with nearly 25 to 30% of the adult population suffering from it. In fact, these numbers may be more since cases are underreported and there is no national venous registry. These patients are at loss to understand where to seek help and often end up with complications such as bleeding, thrombosis or non-healing leg ulcer. Right approach and proper training will help the interested specialists to treat such patients. And we at Samta Hospital and Surekha Varicose Vein Clinic are more than happy to share our experience and knowledge for this noble cause.